And many of you have been involved in healthcare and measures to improve outcomes in rural healthcare. And some of you are those who've been thrown into this situation because of the positions that you hold in administration and who are not familiar with healthcare. And we applaud all your efforts and thank you very much for joining. So that's a very important part that I have to thank all of you for joining on this call. Um, so some of so most of us are aware of the problems that we face in rural healthcare, and that is one of a paucity of resources. There has been, along with the pandemic, a problem of a lot of misinformation, a misinfodemic, if we might, about what is needed in order to achieve good outcomes, or safer are extremely expensive and impractical to use in the rural scenario. Also, some of them are associated with harm, as there has been a paucity of knowledge sharing across the board. Um, Keeping that in mind, I think it's very important that all of us come together to address what can be done as simple measures, so that we look at solutions that are not expensive, that are not harmful, and continue to address that which can be achieved in a much more simple manner across the country. We know that it's not enough to throw tools at a problem without the appropriate training. So these are the problems that we are hoping to address, so that the rural healthcare systems are not overwhelmed, and so that we do not add to the mismatch between the resources available and the needs in the communities. So there is a very strong need across the board to intervene and adopt science-based solutions for the management of COVID-19 in rural areas. We know that a lot of treatments have come and gone in the news. Expensive drugs and therapies have been advocated for COVID-19. However, we also know that COVID-19 is a disease where the majority of patients are asymptomatic or have very mild symptoms. So the idea with this Science Alliance is to come together to have evidence-based practices which can be easily implemented across rural areas, and we focus on interventions that are effective and focus on the fact that patients who can be managed outside of hospital settings are managed so in an appropriate manner with the right support and training provided to the rural healthcare workers. We know that what really works more than anything else is when we cross that border from mild to moderate illness. The things that work best are oxygen, prone positioning, and dexamethasone. And we were just discussing a little earlier, that's OPD, and that's as good as it gets to try and keep the patient out of the hospital as much as possible. The outpatient therapies, if we can maximize our capacity and train healthcare workers in the utilization, that would be one of the ways of strengthening the support that we can provide for rural communities in the management of COVID-19. To this intention, there was a group of people who came together, including clinicians and public health practitioners from across the country and across the globe. So if you look at who are a part of the Swasth Community Science Alliance, you will see a host of names, which includes clinical practitioners on the ground, field practitioners in the area of rural healthcare who have decades of experience, clinical scientists, physician scientists from universities, at esteemed universities, who have a great background in research methodology, especially in addressing public health, and as those who can assist us in monitoring the interventions that we hope to bring about in these setups. So this is what the Swasth Community Science Alliance is all about. It's a group of people coming together as clinicians, public health practitioners, scientists, social scientists, and people who have expertise in monitoring and evaluating data and giving feedback. And I would like to invite some of our colleagues who are on this call right today. So if I can check and request Dr. Kshitij Arora, if you're on the call, if you could come and introduce yourself. I'm not sure if Dr. Kshitij is on the call. He's on clinical service. I'll invite Dr. Charuta Manke.
Hi, I'm Dr. Charuta Manke, Associate Professor of Ophthalmology in Cooper Hospital, Mumbai. It's been a really enriching experience, developing all this. And finally, we are happy to see a lot of people will be able to make use of this really fast on the ground. And the goal is to keep people healthy and save the life. So I think, looking forward to doing more here in the next few days. Thank you.
Dr. Manoj Mohanan.
Hi, everybody. Good morning. My name is Manoj. I'm at Duke University at the School of Public Policy. I teach economics and public policy, and I'm delighted to join this team. I have to say first, thank you to everybody for chiming in today. And we really hope that the work that we've tried to do is going to help navigate this complex environment of misleading guidelines, misinformation that's out there, and also help with efficiently delivering care in this time of need. So I'm delighted to be part of the team. Thank you.
Dr. Amita Sudhir, if I may invite you next.
Hi, I'm Amita Sudhir. I'm an associate professor of emergency medicine at the University of Virginia. I'm also the residency director here. And like everyone else, it's been a really rewarding experience to be part of this response to a crisis situation. And I hope that the work that we've done will have some impact on saving lives in India.
Dr. Sachit Balsari.
Thank you. I'm Sachit Balsari. I'm an emergency physician and faculty at the Medical and Public Health Schools at Harvard. Very grateful to be part of this group.
It's truly been a wonderful experience to be a part of a group that's come together to collaborate and come up with some offerings that we have for our listeners here today, and hopefully many more partners in the future. The Community Science Alliance is committed to evidence-based and contextually relevant interventions for COVID-19 management in non-hospital settings and in rural settings. The idea was to come together to bring the best of evidence and best practices in a manner that's acceptable and implementable across the board in different kinds of settings in India. And to this end, we've come up with a set of offerings, and to talk further about the offerings that we have, I'd like to invite Dr. Sachit Balsari to take over for the rest of the presentation. Dr. Sachit.
Thank you, Dr. Pat. I'm going to share my screen if you can transfer it over to me. So diving right in, the way the Community Science Alliance works, and we very much hope that all of you on this call join the Alliance as well, is to provide a suite of services that have been co-developed with all the partners. We very much want to be available, if so needed, for the entire process of design, implementation, and evaluation of the COVID-19 programs that you are administering, whether these are home-based, home monitoring programs, or they are smaller COVID-19 care facilities that provide oxygen therapy. We will provide a suite of training programs that are suited to the level of healthcare provider that is engaged in your program, whether an ASHA worker, a volunteer, an Anganwadi worker, an A&M worker, or a medical officer. The content library is a public resource available to everyone. But the way the content library, and we will walk you through some of the material that has been developed, will be most effective is if it is integrated into the planning process to see what is relevant, what needs to be modified in your particular context, given the literacy, health literacy, digital literacy of the administrators, right? So this is not a one size fits all. What we will demonstrate here are the foundational templates that then can be modified into whether it is videos or a PowerPoint or a WhatsApp message, etc. But most of the content is pretty ready to deploy, as you will see, and is being translated into multiple languages. The order in which we pick these languages will depend on the priorities that the partners express. This is also very tightly clubbed with prevention strategies. Joining us in a few minutes on this call will also be Professor Mushfiq Mubarak's team from Yale University, who has been working in Bangladesh and with Seva in Gujarat. What they demonstrated through a study of over 350,000 people in Bangladesh is what it takes to go from a recommendation of wear masks to actually getting an epidemiologically critical number of people, of population, to wear masks correctly at all times, covering their nose and mouth, right? There is a difference between saying people should wear masks to an entire community wearing masks such that it actually makes a difference. And they've sort of developed strategies to help do that. 1 million masks were distributed in Gujarat by SEWA, deploying this strategy. And then, of course, strategies to combat vaccine hesitancy. So the material that we've developed is flanked by these two prevention strategies. If your organization has the appetite and the mandate to adopt these as well. The analysis cell and the registries I'll come to in the future slides, but there are sort of side arms to these tools to engage in other ways to advance the evidence around what we're trying to administer. So here's an example of what these toolkits look like. We've broken them into sort of two bins. One is programs for patients with mild COVID-19. Those who can be kept at home, that have just need to be monitored, right? The majority of cases that get COVID-19 will be asymptomatic. The majority of those that are symptomatic, as Dr. Bhatt reminded us, will just need to be monitored safely at home. They do not need a plethora of medications. They do not need any interventions, but they need to be aggressively monitored. That bit is in these yellow booklets with material for the program managers, ready-made material for the patients to have at home and for the healthcare worker to understand how to monitor and how to refer and when to refer. The green booklets are for programs that will also offer oxygen therapy. You know, it is the right kind of oxygen at the right time for the right kind of patient that will actually make a difference on mortality. This is not going to work if we're not sort of accurate about targeting these interventions to the patients that need them the most. What I'm trying to get at is there has been a massive distribution of oxygen concentrators, ventilators, oxygen cylinders and tanks across India. But as we all recognize, especially all of you in the field, this is a very small part of the larger ecosystem that needs to be fixed to provide the trainers to use this in the right manner. Here is an example of sort of the details that the healthcare provider kit goes into. This is the healthcare provider kit for the COVID-19 care facilities, where you see the subtopics that are there. They're all simple. Every green marker on the left suggests a transition from one chapter to another. So you will see that it's hardly a page or two or three, really simplified, and you know, covers an exhaustive range of topics. And we will continue to develop more. For example, the other day, as Arman joined the Alliance, Dr. Hegde, who may be on this call, who's a gynecologist herself, is now helping develop the COVID-19 care protocols for pregnant mothers. And the process essentially is that it is vetted by a team of peers to make sure that it is in concordance with the latest evidence that is out there nationally and globally. Here is an example of detail that is provided for those providers who want to read a little bit more about where the recommendations are coming from. And so if there's a list that says use these drugs or don't use these drugs, it explains on what basis these recommendations are being made. The patient kit, as you see, is even simpler. It's a one-pager. It walks the patient through what to expect at home. What does a home monitoring program look like? You've seen some of this material being developed by several partners across India. And so where there is already content, there is no desire from this group to duplicate that content. We adopt it with permission and say that this is approved by the Community Science Alliance if it sticks to the science. What this will allow us to do is amplify the amount of material that is available to all partners so that each of you is not trying to redevelop this in different corners of India. All the material that you see here has been taken from scribbled notes by physicians to digestible, really easy to use instruction sheets because of Noura Health. So big thank you to them for the hard work that they put in over the last 2 weeks to get this material ready. A critical part of what we would like to do is to really encourage and support teams on the ground to collect at least a minimum amount of data. All of us engaged in the Alliance have worked long years in rural India and understand the constraints about collecting data in those kinds of settings. And therefore, we've simplified this so much that if you look at the bottom right-hand corner of the screen, for circumstances or situations where the literacy levels are very low, even a photograph of the pulse oximeter will do, and we'll provide the services that it takes to take this information and turn it into actionable analysis at the end of the day, so that there is good decision support available to care providers. Ideally, this would be decentralized and happen sort of locally within your organization. But if there is limited capacity in the beginning, the Alliance is more than happy to step in and help. All data stays local, all data ownership stays local, etc. Right? The idea is to just help understand exactly what impact these oxygen interventions are making. This is uncharted territory. We've distributed all this equipment. We really need to know which patients can safely be cared for home in the rural setting. And what we have are national and global guidelines, but having this accurate information will allow us to fine-tune and calibrate for state to state, for interstate differences. I don't believe Dr. Arora has been able to join yet. He is on clinical rounds right now. This is a global registry that Dr. Kshitij Arora has started with partners from India. We desperately need to know, what is driving the mucor epidemic that we see in South Asia. And the time to do it is now, even for all these rural communities. There are, of course, all these hypotheses about the steroids and the antibiotic use, etc. But it is important to collect just basic information about who are these patients, what is their age, gender, what medications have they been on, severity of COVID-19, etc. It'll really help us fast calibrate the correct response, both for therapeutics as well as for preventing mucor. This is a completely de-identified registry with ethics approval. So those of you on this call that are affiliated to hospital settings or clinical settings that have seen a large number of mucor patients, please ping us and we will share the links to the mucor registry. We'll also drop it in the chat right now. But it's easy to navigate and has all the requisite data protection platforms in place. I'll pause there with a summary slide. So the way we have envisioned the Community Science Alliance is that it is not just the box on the left. It is really important that we be available throughout the entire journey. So we will be available to the training partners, looking at the training material, making sure that the final products that have been produced reflect the intended content of the scientific material. And through some of the data interventions that I shared with you, work with the field partners to make sure that the material is reaching its objectives. If it is not, there needs to be these quick, rapid iterative cycles that help us change the content, change the training, so we can very quickly have the desired clinical and public health outcome on the ground. So it's very human intensive, humans in the loop constantly, but that is sort of all we have at this stage in rural India to make sure that these lives can be optimized. In summary, what we are trying to do is to keep folks at home if they can be safely kept at home and monitored at home. I think there is national recognition now that this can be done and is important. But the next part, which is around the oxygen therapy, really needs to be protocolized such that we're doing the right interventions, keeping people safely away from hospitals when it is possible to, so that we don't flood the hospital bed capacity, which we don't even have to begin with in rural India. I will pause there. A shout out and a thank you to the entire Swasth team that has worked with these physicians and scientists to get all this material to this part, as well as all our research associates and affiliates at our respective institutions that have made this possible. As I hand this back over to Ajay, what we would like to now hear from the group, as you are asking us questions, a quick 1 or 2 lines about the kind of program that your institution is involved in, and how this material that we presented can be integrated into your deliverables. What would the next steps be? How can a resource like the Alliance best support you? And if you have any concerns, please bring them now. This is an open platform and is a public service. So the more you can direct us and advise us, the more useful this will be. Thank you kindly, everyone, for listening. The floor is open. Ajay, over to you.
Thank you, Sachit. And I just wanted to say this again, that all of these clinicians have been keeping pretty busy clinical schedules, as well as dealing with personal emergencies while they work nights and weekends to get this done. So thank you to everybody. The floor is now open for questions. Folks can either raise their hands and we'll call on them, or they can type questions into chat or come on and ask the question. There's a few questions in chat, which I can quickly read out. I think there's one question on pregnant women and whether there's toolkits available for pregnant women. Dr. Bhatt had answered that, but Dr. Bhatt, would you like to elaborate on that?
I think so. Arman, led by Dr. Aparna Hegde, have already been developing the training material for community health workers, and they're also going to help us with developing the toolkit for the management of COVID-19 in pregnant women, lactating mothers. So that should be ready shortly, hopefully within the next few days.
Thank you, Dr. Bhatt. We have Dr. Neena Jaju. If you could just quickly introduce yourself and then ask your question, that'd be great. Thank you.
Thank you. I'm Dr. Neena Jaju Pingle. I am heading the content and learning science at a social organization called LabourNet. And we are intensely involved into the vaccination drive and created a lot of content. I'm from an education background, basically an instruction designer. And we have developed, with the help of a similar team of doctors across the globe, and a lot of content designers and instruction designers, we've created courses for vaccination drive, where how, based on the WHO guidelines and the guidelines from Ministry of Family and Health Welfare, what the vaccination team would look like, and so that we can facilitate the complete process of vaccination, right from the role of a vaccinator, knowing that there will be a shortage of doctors, so there would be maybe the medical students or the pharmacists who would be there, and therefore looking at that, contents have been developed. And also content has been developed for community mobilizer. And I think the content that you are talking about would be beautifully complementing with ours, because this is the part which we have not worked into, and we were thinking that we should be working into, before even when COVID is there, how to prevent. The prevention itself becomes such a big thing. And of course, in parallel, the vaccination. So I think these two things together would work beautifully for us also. Thank you so much.
Thank you so much, Dr. Jaju. We've also had conversations with Gayatri and Lipsa at LabourNet, and we'd love to collaborate. And we are really looking at LabourNet as a collaborator.
Absolutely. That would be beautiful. Thank you.
Thank you so much. There's a question here from Dr. Bharat, which is, do the protocols account for differential diagnosis, especially co-infections and false positive negative reports, before we assume the case is COVID-19?
Yeah. Can I take that question?
Please do.
Yeah. So thank you for that question. And keeping in mind that we're heading into the monsoons across the country, we have in our healthcare workers, the providers kit, a toolkit for the labs that need to be ordered or investigations that need to be ordered. We've tried to keep it as simple as possible and not as complex as the battery of tests and blood tests and imaging that we're seeing across the cities. And that does include the differential diagnosis. So the healthcare workers will be trained in picking up on warning signals, and will also be alerted as to when blood tests are necessary, and the blood tests will account for differentials like typhoid and malaria as well. I hope that answers your question, sir.
Can you just add to that? This is tough. I think in April, we would have answered this very differently and said, in the middle of a pandemic surge, if you have COVID-like symptoms, don't run around trying to get a test when it's not available, and you have to assume that it's COVID-19. I think all of this goes, is tossed out of the window in the monsoon season. Again, I think it's risky to come up with a blanket solution for all of India, and we should work with specific organizations and say, what are the tests you have access to? What is the endemicity of either dengue or malaria or the waterborne diseases, and then sort of build off what Dr. Bhatt just said. Is protocolize it such that it is relevant to the resources that are available, and at some point none of it might be available, and we may have to stick to empiric therapy, which is often done in these towns, where in the monsoons, if you're getting cyclical fever, you assume it is malaria and so forth. So that's what I would say, saying that there is some backbreaking work that needs to be done early on at engagement with any organization. And again, this is a reality for all of you. I think we overlay COVID on top of it to say, if we have to empirically diagnose COVID, then if there are no tests available and you're assuming this is malaria, should you be watching the oxygen saturations more carefully, for example? And that's all it might come to.
Can I add one other thing to that, Sajid?
Go ahead, Manoj.
Can you hear me?
Yeah, we can. Yeah. Go ahead.
Sajid just described exactly what one might do when there are no tests available. But a harder question might also be when there are some tests available, not enough to clearly test everybody, but it's clearly not zero. And one thing I would suggest we might want to think about is the possibility that when you're working in communities like this, you could use the few tests that you have to do random samples to be able to address that underlying question that Sajid mentioned, which is, do you really know what the level of endemicity is? And can you actually say something about whether what the status of the epidemic in that community looks like? It's not that hard to do. It would require a little bit of planning on the sampling and stuff, but we can help you with that part. But the key point simply is, if you cannot test everybody, and if you cannot test nobody, then there is some middle ground in there. And rather than making allocation decisions, you can use that information to understand what the underlying epidemic looks like. Thanks.
Thank you, Manoj. And I see, Geeta, I see your hand, but before that, there's a couple of questions on chat, which I think are important to call out. So there's questions on floods, waterborne illnesses, seasonal illnesses, which are now going to come upon us with the monsoons. And I think there are questions on how do you really separate them from COVID-19 in the absence of appropriate testing. And I think it's a very important question. So Dr. Bhatt, over to you.
Just more of what I said, Ajay. That's exactly going to be the challenge in the monsoon. So I don't have much more to add. Rajni, other thoughts?
I think it's going to be about seasonal illnesses that come that is part of our community health monitoring systems in any case. It's just about adding that extra layer of vigilance, which is about COVID. So when we look at the fact that you're going to be screening for symptoms and having a syndromic approach to it, but when we look at the fact that we're also monitoring oxygen saturations and things like that, that will allow us some degree of differentiation. So we're going to have to keep in mind these differentials, but really work on training on picking up the differentiators with the people who are supervising the healthcare workers. I think that's going to be the key here.
There is, again, right, on one hand, we're resource constrained, but on the other, some of the new discoveries and new devices allows the kind of point of care testing that was not possible even 5 years ago. So if there are organizations that have the capacity to look into selected POCs, then even for diarrhea, waterborne diseases have been brought up repeatedly on this call, and it's really hard to change the ethos of throwing antibiotics as what is likely to mostly be viral. That being said, in the South Asian subcontinent, you do have a reasonable burden of diarrheal diseases that are bacterial that do warrant some antibiotics. There is literally bedside ready to deploy genomic sequence testing that is available, that is a small kit, smaller than your phone, can be plugged into a laptop. For those of us that trained a long time ago, this sounds like sci-fi and completely irrelevant to the Global South context, but it is precisely made for this. And we did some pilots with us in Bangladesh last year before the COVID-19, in the Rohingya camps. And it was quite successful. It needs training, and not all of our organizations are going to have the capacity to do that. But those that do, we could do that. And I think there's a mismatch often, sorry, a gap rather, between new technologies that are available and the places and the capacities that actually need them. Again, we're sort of rapidly getting into some sophisticated but very simple interventions, but happy to convene meetings to have those conversations for you.
Thank you, Sachit. And I want to call on Geeta Manjunath from Niramai, who has had a hand raised.
Yeah,
Geeta, if you
thanks.
could tell us a little bit about Niramai too, that'd be useful as an intro.
Yeah, sure. Thanks, Ajay, and wonderful initiative by Swasth as usual. I mean, wonderful. So I'm Geeta, CEO and founder of Niramai, where we've developed a new method of detecting breast cancer using artificial intelligence and thermal imaging. My question was really, of course, one aspect is like, how do we actually make the breast cancer screening itself sort of, in large, in scale, at large scale, so that, every rural community will have a very affordable, accessible screening. And we are trying to work with Swasth to get some adoption in some cases, right? But my question at this stage is more in terms of another initiative that we have recently started, particularly to address this current COVID issue, in trying to enable technology to enable early screening, right? Quick screening, quick interpretation. So specifically, we have developed a WhatsApp-based chatbot working with IAC and Art Park, where a rural doctor can just take a picture of the chest X-ray and message it to a WhatsApp number. And our AI basically sort of gives an indication of what the likelihood of pneumonia, etc. So this one we feel that when there are delays with RT-PCR and so on, this probably can act as a additional supplemental screening, so that if a person comes in, just says yes, and then quickly we can put them onto the medicines and ensure that he's quarantined and family members are tested and so on and so forth. So this is sort of meant as an immediate thing. We had actually piloted this last year in the first wave with some 200-300 doctors and 255 doctors to be specific, and it was really helpful. So, so two questions here. So one, how can we leverage the huge, expert panel here from the clinical expertise to one, really validate on the ground exactly where should we be using this, and are the results good enough for on the ground at a nationwide scale? And second, how can we actually increase the adoption at this stage where, the country is struggling to get screening done?
Can I take a quick stab at responding? So thank you very much for that suggestion. And what you described about the WhatsApp-based bots, that's very similar to what we have been trying to develop to enable quick feedback to the frontline workers. So one big difference I want to maintain is we're not trying to provide a diagnostic tool or a decision support system. That's probably beyond the capacity of what we can develop and what we should wade into at this point. Instead, what we are trying to do is help the managers of the centers and the frontline healthcare workers understand whether two basic things are being done. One is monitoring of the patients, and whether patients are getting the very basic thing which we talked about, which is oxygenation and proning. So imagine you're the manager of a 50-bed center or a 25-bed center. You might have trained your staff and you believe that they are actually monitoring patients twice a day and doing this. How would you know whether it's happening or not? That's the first order question that we are trying to address. So by simply collecting information from these very simple checklists, where all the nurse or the doctor does is checking off boxes every time they walk by the patient, you would be able to understand whether these protocols are being monitored or not. And then subsequently, you might want to go in and figure out, well, why is it that my center despite training and instructions, is not able to monitor, and you might be able to address concerns there. So we can try and get at that, but the more important point about providing decision support system, and frankly, it's outside of my clinical expertise, and my clinical colleagues can tell you more. I also worry that we might not have the bandwidth to be able to support individual organizations at that level. I think that has to be done more locally. But Amita, Rajni, do you have suggestions? Over.
Yeah, I think regarding the chest X-ray, and there are a few questions about that in the box as well. Chest X-rays and even CT scans, it's helpful if you find the characteristic findings of COVID, but in many cases, they're going to have a normal chest X-ray, or you're not going to have CT scan findings, regardless of the expense and the difficulty of obtaining a CT scan. So while it's helpful to have a positive test, if you only have that and you don't have access to PCR, maybe that's a possible way to make the diagnosis. A negative test doesn't really help you. So if you're relying on that imaging finding to see whether or not a patient has COVID, you could miss a lot of cases. So I think it's really important to keep that in mind.
Yeah, we have fine-tuned the AI to have high sensitivity for the reason you mentioned. So that we we try not to miss any COVID cases, but there may be some false positives. So that's how we have currently trained the model, and it does have some high sensitivity, over 95.
Thank you, Geeta. Wanted to check if there were any more questions. There's about 15-20 minutes left of the call.
I see Deepika's raised her hand.
Hello, good evening.
Deepika.
Hi. Please go ahead.
Yeah, thank you very much for a wonderful presentation. Has put a lot of things in context. I want to understand about the Community Science Alliance. However, there is just one thing that I would need a little more clarification on, is that when you're talking about a syndromic approach, how are you looking at COVID-19? Are you looking at it primarily as a respiratory illness or as a systemic inflammatory syndrome, which it is now coming out to be more in the second wave and definitely in first wave also? But how are you looking at it?
So it's nothing that. I'm just sort of fixated on saying how we're looking at it. It's really not sort of how we're looking at it, but really just what the science shows, right? And you're absolutely right about it being a systemic illness, but it isn't at the point where we're doing syndromic surveillance. So the approach to this would be not different from what it has really been over the last 12 to 14 months around the world, where initially you're looking for the early signs of COVID-19, which, depending on the variant and what time in these last 16 months, either has a respiratory predominance or a GI predominance or both, right? We had at some time it was always anosmia, and then at other times in other localities it was always a GI cluster of symptoms. So you do both. To most accurately answer your question, Deepika, I think it depends on local endemicity. Right, and so in a community where there is not respiratory illness and there is COVID-19, if you are developing respiratory symptoms, you assume it is COVID-19. This was very tough in the United States, for example, in the winter, when we had assumed that we would not be able to distinguish between flu and COVID-19 because they would present with same symptoms. It's a totally different matter that we did not have a flu season this year in pockets that were masking appropriately. Your question is so relevant to June, July, and August with the monsoons for the reasons we said earlier, right? Because syndromic surveillance with waterborne diseases and malaria and dengue just completely derails any linear pathway, which is where I think we have to go to each local context and try and get a sense, like Manoj had said, on what empirically what disease is most likely to predominate. Oxygen saturation has, there's enough data over and over repeatedly validated that oxygen saturation is a good marker for prognostication. So even if you're thinking this is another disease, follow the oxygen saturations if there is any doubt that this is going to be COVID. Because even if you miss COVID, right, if the oxygen saturations didn't drop and this ended up being a mild case of COVID, there's no harm. But if we're thinking that this disease is something else, and you see the oxygen saturations drop, it is the one a characteristic that has repeatedly shown to be a fairly accurate marker of prognostication. So that's probably the way to approach it. But I would flip it around, Deepika, and says it is not about how we would approach syndromic surveillance, but really how would the team on the ground approach syndromic surveillance in their local context.
It's very helpful. Thank you. I just wanted to, I understand that for health workers, for paramedical staff, for nurses, yes, you have to have a very, very simple measure. But for medical doctors who are there, it may be useful to give them a little more information on it, and probably you could titrate it that way.
Absolutely.
Absolutely.
Completely agree.
Can I also add, we are developing a resource folder where exactly this kind of information will be compiled and populated over time, so that the medical doctors who can understand this literature can go deeper and learn more about this as well. So thank you for that, Deepika.
Thank you.
Dr. Bharat?
Yeah, so we've worked with this problem of acute undifferentiated febrile illness and how COVID-19 would fit into that differential diagnosis. This was done with the Indian Institute of Public Health over 6 months last year. And we found that there is very little epidemiological information available for any areas in India. And the best days to get this right was the first 4 days.
Mhm.
So if you're able to hit the right diagnosis in the first 4 days, then you can actually prevent all the comorbidity that could stem. But what we didn't find promising was oxygen saturation cannot be used as a marker to differentiate, because there's so many diseases, for example, dengue, in which you would later on could have drop in saturations due to other complications, while the treatments are exactly opposite. And you can always have co-infections. So this is a toughie to crack. But we can share the protocols that we developed to manage COVID as a part of AUFI diagnosis.
Dr. Bharat, thank you. We might want to circle back to you after this call in a day or two, just to learn a little bit more and see if you can help advise or lead figuring out how best to approach this. So many folks in the chat have asked this very same question, that it may be best for us to learn a little bit from you and come up with some directions on how people should think about this.
Thank you. Happy to share.
Thank you all. Any more questions?
May I jump in for a second? Sachin, a number of people have asked about where the resources are. Perhaps we could show them a screenshot of the website or tell them what's happening with the website so that they can know where to find this, even outside of our email communications.
Thank you. Yeah, Sachin, you're on mute. I think it'll be great to do a walkthrough. Thank you, Manoj. Makes sense.
So the website URL, we'll drop it in the chat again because it got buried, is science.swasth.app. You know, bear with the simplicity of the website. We've avoided bells and whistles, but the team members promise that it'll look more interesting soon. Just go to services on the left. And when you come to services, you basically have two choices. Are you setting up a home or community-based self-monitoring program? So essentially this is without oxygen. And the second one is with oxygen. And if you click on it, literally all three kits come up: manager kit, healthcare worker kit, patient kit. If you want to download everything, I mean the entire kit, you go to patient kit and it'll download the whole kit. If you go right to the bottom, you literally get the entire kit, all three kits. Click here to download the COVID Care Center kit. Will help you, it'll just download onto your website. Individually, if you want to look at what these are, you click on any one of them and you can essentially scroll through all the content. each of these can be downloaded, and the translations will also be available on the website, and the pages will be tagged quite obviously. So on the right-hand side, you will see that you have a menu that takes you to the various resources. Right? How do you order labs when you don't have labs, etc. Right? All of that is included. Similarly, the home monitoring kit, I'll just take a minute to show you for the administrators, it's very simple checklist. Here are the things you should be thinking about before you start. There's a lot of voluntary efforts to say, oh, we'll start a home monitoring program, but often then the same scrambling for ambulances and where to send the patient remains. And we suggest that, look, you first think about this, right, before you start a home monitoring program, so that there is some kind of referral pathway, etc., how to maintain data, and so on. And there are details for sort of how to manage various data sets, how to train the community health workers and the medical officers to keep these data, and so forth. I think that should be good enough. It's quite self-explanatory, and please ping us if you have questions. Also, these can be emailed to you. The goal, again, is to do a customization. You look at the material and say, yes, it's ready to use, versus no, we actually need a slide deck from it, or can we co-develop 2 videos from it, etc. There's no proprietorship. There's no sort of, this is a global resource for everyone. And if you have resources, like many of you said, like Dr. Bharat was saying, please feel free to share with them. If we agree that it sort of hits all the scientific benchmarks, it becomes a Science Alliance resource. You retain your authorship over it, but make it available to a wider audience.
I also wanted to invite Dr. Sudhir to speak a little bit about the value of CT scans as a prognostic tool or not.
Yeah, I don't think there's any evidence that suggests that the appearance on the CT can be a useful prognostic tool for, who's going to desat, who's going to need transfer to the hospital. So if it's being used in that way, there's a danger of either over or underestimating somebody's ability to function without oxygen or be okay at a lower level of care. So I think it could really go in both directions. There's a lot of expense and radiation involved, and I think there's a danger in making a incorrect clinical decision because of it. Speaking from my own clinical experience, yes, it's a different strain in the US, but it's still COVID, still affects the lungs in the same way. We've had a lot of patients who got CT scans because they were involved in a car accident, for example, had really horrible looking lungs, but their COVID infection had been, 2 weeks ago, they'd been fine at home. So I think there's a lot of danger in making incorrect prognostication with that. Because there's so many questions about it, I think that we can really put our heads together and create a guideline looking at the evidence. And I think that would be helpful to help guide people in deciding whether to do that. So that's certainly something that we can address in our packet as well.
Thank you so much, Dr. Sudhir. Any more questions? Dr. Sathav, I just saw your hand raised.
Yeah. Thank you for a nice presentation of the speakers. Actually, I have one query in my mind. Like in tribal area of India, which constitutes around 10% of the Indian population, and similarly 20% of Indian population in rural part of Bimaru states, the situation is very worse. There are no doctors, no facilities available. We are thinking of training the village health worker in the villages itself, who can be trained for monitoring of SpO2 with pulse oximeter, and second, rapid antigen test, which is also feasible. And if and most of the patients are dying in such area because of delayed diagnosis and delayed referral to hospitals. If the village health worker can diagnose COVID with hypoxia, and if they will treat the patient there in the beginning with steroids and low molecular weight heparin, is it advisable scientifically or not? That is my big query. But I think that is one of the solutions to prevent deaths in such areas. And second is, we have treated more than 100 critical patients of COVID in very resource poor setting of Melghat without facilities like CT scan and D-dimer. And our death rate is very less. It's around, in critical patients, it's around 12% only. So I think CT scan is not that important for treatment of COVID-19. It's my personal opinion of experience.
Hi, can I take that?
Please.
Thank you so much for that, and that's really commendable. That your death rate in critical patients is low, and that you have not had to, use a lot of CT scan. But and the idea here is, of course, to train in low resource settings, and we do have a kit for that also. So it would definitely be useful in such areas where there are low resources, and the training kits would definitely be useful. The next thing is that we are going to collaborate with training partners who would then be able to facilitate this training and take it to these areas which you need. So that's going to be like a possibility really soon. And then of course translation into languages which are on a priority basis, which are needed immediately, so we can focus on that too.
Thank you, Dr.
Dr.
Malke.
A specific question about whether task shifting should be allowed for steroids and anticoagulation. I think this is, so purely scientifically speaking, of course, right? And organizations like yours, like Mahan and Search, have always pushed the boundary on what community health workers can do, right? Including PILs and court cases. So I think this is a local decision in terms of what is possible, what is not, when there are no resources. If the question is, does the science support task shifting of administration of steroids when it is protocolized, or perhaps even anticoagulation when it is strictly protocolized and under supervision? The answer is an unequivocal yes. The science supports that is the only way to do it. On our call today, we have Dr. Richard Cash, right, who is one of the team of 3 folks decades ago that formulated oral rehydrating salt formula, in the cholera camps in Bangladesh at a point when the care for diarrhea was expensive. It required IV tubing and intravenous infusions, which were not available. And we converted, 40, 50 years later, the way we physicians treat even cholera now is through oral hydration, right? So simple interventions that were done at the bedside. All of us have grown up with television watching How to Make ORS. So just sort of want to remind all of us that we need to demystify the complexity of COVID care for the majority of patients, where Rajni came up with this lovely acronym in the morning about OPD treatment. It's really oxygenation, pronation, and dexamethasone that this tiny slice requires. And there is no reason why our patients in rural India would have a different outcome than patients anywhere else, anywhere in the world, if the right interventions are administered. Ajay, over to you.
Thank you, Sachin. We're getting to the top of the hour. If there's no more questions, then we can close. I also wanted to share that, if you remember such second last slide, the idea here is that there's a core set of content that is created by the Swasth Community Science Alliance. We are also working with a bunch of training organizations to transform these into training of trainers that can be then implemented in programs around the world and around India to begin with. Sorry, apologies for that. But that's the idea here, is that there is core content that the Swasth CSA creates, which then gets taken to training partners who then work with the field partners. In some cases, the training partner and the field partner are the same entity, but in many cases, they might not be. So that's the other piece that we will work on. So feel free to get in touch with us. We'll drop some contacts in the chat so people can get back in touch with us. But you could also write to contact@swasthpap.org. We'll just drop that in the email right now, in the chat right now. All right. Thank you all for joining. Thanks again. We're very grateful for the fact that everybody's taken a time from their Sundays to join this. We're really hoping that we can work with programs around India to make an impact with this work that is ongoing. Thanks again to all the clinicians who've spent the last few weeks working on this relentlessly, and the team that's been actually helping put this together. Thank you all.